we are planning for full mouth implant for this patient. First we plan for mandible. So what is the basic guideline for to consider before going for full mouth implant in mandible? We will discuss now. So first planning is how much alveoloplasty needed, where to do the alveoloplasty. Okay, most of the time there will be anteriorly there will be a supraeruption along with the alveolus. Okay, so you have to do a good alveoloplasty here. Sometimes even in molar region you have to do alveoloplasty. Okay, so there will be supraeruption of anterior or posterior segments when there is edentullousness, partial edentullousness for many years. The teeth tend to supra-erupt along with the alveolus. So if you don't do alveoloplasty, there will be a less prosthetic space. In this case, we will be doing alveoloplasty in the anterior region and in the right lower molar region. So it is a recently extracted socket. Around about 1 month back, the patient got the teeth removed somewhere else. Okay. So one advantage of doing alveoloplasty is we are getting good prosthetic space, a even prosthetic space, and we are removing the poor quality alveolar bone and we are removing the thin knife edged alveolar bone so that we can place the implant in a good quality bone. Okay. So not doing alveoloplasty is one of the mistakes beginners do. Okay. So this will lead to problems in prosthetic constructions. Okay. So how much alveoloplasty you need to do? You have to use this 3D reformated view. You will get a fair idea, and also to correlate with the clinical prosthetic space. Make the patient large in the CR position. Okay. Then you can evert the lips and you can judge how much prosthetic space is present on both right, left, and anterior spaces. Now we will. So the first step is alveoloplasty, where needed, how much needed. These are the two factors. So the second plan is how many implants you are planning to do. So there are basically two plans you can execute with single piece implant. One plan is 8 implants and another plan is 6 implants. Of course you can place even 7 or 5 or even more than 8 also. But these two are the most commonly used plans, 6 and 8. So mandible you can divide into two parts. One is the interforamina area or anterior mandible, and the second part is the distal mandible. So if you have got good bone both in the anterior mandible and the posterior mandible, you can go for all on 6. Okay, 6 implant is enough. When there is very less bone in the molar area, distal mandible, you may have to go for 2 implants in the distal mandible. So the plan changes into 8 implants. Okay. So out of 6 implants, 4 implants will be in the interforamina area and 1 implant each in the distal mandible. If you are going for 8 implant plan, there will be 4 implants in the interforamina, 2 implants in the distal mandible, 2 implants in the distal mandible on each side. So this is one plan. Or you can place 6 implants in the interforamina area and 1 implant in the distal mandible on each side. Okay. If it is 6 implants, 4 implants in the interforamina, 1 implant each in the distal mandible. If it is 8 plan, there are 2 variations, either 4 or 6 implants in the interforamina and the rest in the distal mandible. Okay. So coming to 6 implant plan. Okay. So if you are planning for 6 implant plan, I told anteriorly 4, distally 1 more. So those 4 implants you can place all straight, or you can place it like a all-on-4 tilted style, where you place the tilted implant just anterior to the metal nerve exit on each side and 2 axial implants. Okay. So this situation, the patient has got good bone on both anterior and distal mandible. Both plan is okay. 6 plan, 8 plan, both is okay. So when we are executing the 6th plan, there are two variations. Okay. One is you can place all straight, or you can place only the premolar implants tilted, similar to all and four. Now we will plan this patient like that. Okay. So whenever you plan to place tilted implant just anterior to the mental foramen, definitely you have to open a good amount of flap exposing the mental foramen. If you see here this is the mental foramen. Okay. Mental now exits and it goes distally. You can see the depression distally. It is not coming anteriorly. It goes and then turns back. But if you see the left side, this depression is very deep. You can see, no? The mental foramen travels till here up to tail and crest. So when we are opening the flap, we should be careful not to damage the nerve. Can you see the depression? This channel is going till the crest. Okay, this is a variation. Now we will place implants. So whenever we are planning for all on four style tilted implants, we have to start from the first or second premolar and tilt mesially, avoiding the mental foramen. See the mental foramen to here. So usually it will be around 16 mm implant we can place, 4.1 or 4.2 depending upon the brand you choose. So this is the 360 degree view. You can see this is the mental now anterior loop is coming. Okay. So when you are tilting the premolar implant, so there are two categories from where your drilling starts, whether it is the first premolar or second premolar, or between second premolar and first molar. The location of the mental foramen determines that. Okay. Then how much tilting you are going to give mesially. If you tilt too much mesially, our anterior implant may come closer to the tilted implant. If the tilting is very less, you may injure the mental anterior loop. So a correct amount of tilting is indicated. Okay. So whenever you plan to place a tilted implant just anterior to the mental foramen area, it becomes a technically sensitive procedure. Okay. You have to be very careful. The tilting should be correct angle, not too much tilting, not too much vertical. Otherwise, either you may injure the nerve or you may interfere with the anterior implant placement. So if you want to avoid all these things, what you can do is just place one axial implant in the first premolar area. That's it. It's very simple. Okay. And place one more implant in the lateral area, and one more implant in the lateral area. Okay. Okay, just 4 implants in the anterior area, just axial. This is also okay. Okay, so in this technique you don't have to expose the mental foramen fully. You just need the landmarks for the first premolar. If you know the first premolar socket, you can place 2 axial implant and 2 axial implant in the anterior near the laterals. Technically it is very less sensitive, less time consuming. Okay, less risk for injuring now. But if you give tilted, the mechanics are better. Okay. So you can see the thin ridge, so that is why alveoloplasty is better. You can place up to 13 mm implant. Commonly the tilted implant will be around 16, the anterior it will be around 16, sometimes it may go to 13 also. So what is the length you are selecting depends upon the height of the mandible, not only the height of the mandible, upon the density of the bone also. The density is very thick, better to select a shorter length, otherwise the implant may get stuck in the middle way. Okay. So don't always go for a longer implant. Even shorter implants will work. So now we'll tilt it. Sometimes the situation is, if you place a straight implant in the first premolar area, the bone quality may not be good, it will be more cancellous. But if you just tilt from the second premolar, the implant will be surrounded by a good quality bone. So that is another reason for tilting. Okay. So we will place tilted for this patient. Okay. Now after that we have to place one implant in the molar distal mandible. Where to place? Whether to place the first root, mesial root or distal root of first molar or second molar. That depends upon where is the good quality bone. If you can place a good minimum 10 mm is needed for a compressive implant, because you are going to place only one implant. Better to select a wider diameter, 4.1 or 4 or 4.2 into 10 mm. If the length is less or if the width is less, better to place two implants. Either two compressive short implants, 8 mm also okay, or you can place a basal implant, BCS implant in a lingual cortical. So when the distal mandible bone is deficient in quantity or quality, go for two implants in the distal mandible and convert into two 8 implant plan. Okay. Now we will plan for the right side this patient. This is the mesial root. Of course we will be doing some amount of alveoloplasty here. Okay. Don't know where is the nerve, but 10 mm we can definitely place. Maybe this may be the nerve. It is too cancellous. When the bone is too cancellous, the nerve also merges with the cancellous bone and it is difficult to see. Okay. This is the mesial root. We will try the distal root. Here the nerve is seen. This is the distal root. This is the nerve. Definitely you can place a 10 mm implant. What you see, this is the distal root. You can see the myelinoid ridge is starting. So you can drill close to the lingual plate and you will be touching this good quality bone. So you will see the plan in mesial root. If you see the mesial root, the myelinoid ridge is not prominent. So always it is better to go for a distal root of first molar. If you go to second molar, that will be much better. You can see, and if you tilt slightly distally the implant, okay, your abutment will be in the distal root of first molar, but the apex of your implant will be in the second molar, engaging the in close contact with the myelinoid ridge. Okay. So these are the small variations we can do. See, I am starting from the distal root of 7, okay, and tilting slightly distally. You can see the myelinoid ridge is very prominent, and you can even try lingual cortical engagement in the ear. Okay, that will give more stability and support to the system. This is the second molar. Okay, so these are the When it comes to left side, the situation is little challenging because there is severe bone loss. I don't know where is the nerve, but it is very small, right? If you go slightly in the second molar, you will see the nerve. In the first molar area, the nerve disappears. The nerve disappears because of that too much cancerous bone. So if you want to see the nerve, you check the 7 area. So this is the 7 area. You can try lingual cortical engagement beautifully here. About 10 mm implant you can place. Good quality bone. Either BCS or compressive. If you are planning for BCS, better place 2 implants. See, I am shifting. See, this is in the. I am slowly shifting in the first molar area. So this is in the first molar area. Okay. The problem is the mental foramen distally travels, creating depression here. Imagine if we drill from here, we may injure the mental foramen. Mental foramen exits in the second premolar area, but it travels till the first molar area, creating a depression and channel. So better in this case, we will start implant placement in the second molar area, which is very ideal. Even we have got a good myeloid ridge. The only thing we have to drill properly. See, if you place close to, the most common mistake is drilling close to the lingual plate. There will be thin bone remaining on the lingual side, risking bone loss and risking fracture while bending. Okay, we have to leave sufficient lingual bone and drill it. See the angulation. A slight distal tilt will do a lot of good. Okay. See here till this depression comes. So better we open the flap here and remove the nerve away from the channel. Just reflect the nerve away from the channel. Okay. Just it is creating a depression over the surface and it is good. Just if you reflect the periosteum, along with the periosteum the nerve will go away. You don't have to worry about, stare about anything. Okay, it is not deep into the bone, it is just adapted close to the bone, that's it. If you do a flap reflection under the periosteum, nothing is injured. Okay, so subperiosteal reflection of the flap, you won't injure the nerve. See, what I am telling is, you can see here. You can see here. See here, no? The nerve is exiting and creating a channel and exiting till here. Better we open the flap nicely here and do the drilling. If we do flapless here, we will be drilling through the this depression, poking the nerve and injuring it. Okay. So that is why flapless is not always good. So nothing wrong in opening the flap.